All right, so we're back for round two. So hopefully you had the opportunity to check out the previous video, which talked about just how millennia of famine have impacted the anatomy and physiology of South Asian bodies. So that just shows us predispositions of what we've encountered and what we are up against. So if we don't do anything about it, then modern day health issues are going to arise. So now we take a deep dive into what are we actually seeing when we put ourselves under the microscope and from a scientific perspective look at what is the current health status of South Asians all over the globe. And it's very similar to those that are actually over in South Asia, to those that are living in and around the UK area, to those that are in North America. And you can imagine anywhere else all over the globe, people are experiencing very, very similar things. So this is to continue to expand on why we are the way that we are. So there are definitely unique aspects of being South Asian. And the previous video kind of talked about why it's very, very difficult to deal with some of the health issues that we currently have if you don't do anything about it, which is very common within the population and it's very common within the culture. So there are amazing things about being South Asian. We definitely have incredible family ties. We've got great culture and history. We take care of each other. We have amazing work ethic, and we always look out for each other. If South Asian sees another South Asian, especially in the older generations, more than likely they are willing to strike up a conversation, even if they weren't inherently born in the country that they currently reside in. And I think that's a beautiful thing when we look at how people actually act and react all over the globe. But on the flip side, because of family and cultural pressures, because of a strong work ethic that's tied specifically only to academics and work and trying to advance up the quote unquote corporate ladder, there is a significant issue when it comes to health because it isn't prioritized and it's constantly overlooked at all ages throughout lifespan. So we've already talked about genetics quite a bit in the last video. So if you haven't seen it, definitely go ahead and check it out. Now we talk more about epigenetics, some of the things that get turned on within your environment based on a lot of the things that are actually within your control. And we also talk about how cultural influences and modern day lifestyle are showing up with what we see when Indians are put under the microscope and studied. And it's important to be very aware about where we actually are when it comes to our health status, because by far and away, I will say this, we have the worst health status on the planet. We are very unlucky. I think I say this quite a bit. We got the short end of the stick when it comes to our physical and metabolic genetics. So a lot of that has already been touched on in the previous video. And again, I'm going to talk about what does the literature show with how we present in modern day times. So we just take a step back and just look at something as simple as life expectancy. And this is cumulative. So even with modern day advances in health and technology and pharmacology, the average life expectancy for South Asians, 67 years, and it ranges, obviously, and that's the lowest in the entire world. Just look at the data. Women generally live longer than men, and I think that's something that's very common and very true with what I've experienced and seen with my older family members. Obviously, I'm trying to buck that trend. I'm trying to surpass everybody, and I think, I've already created the blueprint, and I'm in my prime, heading into 41, and know exactly what to do. And obviously, the goal is to share that with as many people as possible. Once we come to the realization and understand who we are, what we are, where we came from, where we currently are, and what it is that we need to do, then we can and should be empowered to make small changes, not only for ourselves, but everybody that we're exposed to and associate with, within our family, within our culture, your older family members, your kids. And that should be something of a priority to, and not just advancing academically, socially, and within your career. Because what's the point of having all of that notoriety if you look and feel like shit and you're aging very, very poorly, which is true within the South Asian culture. So this just talks about healthy life expectancy at birth. Now, it's going to be different where you look at it across the globe. Life expectancy here in North America, here in the United States, for South Asian is going to be significantly higher because of advances in access to healthcare, how we end up living. When you look at the SES demographics, Indians are at the top in America in terms of what we make and bring home. which allows us to spend more money on healthcare when that time comes. But nobody's being proactive about it because everybody's just kind of walking around um, playing dumb when it comes to what you can and should be doing because they're not empowered by having this information. And that's the purpose of putting it together. Leading cause of death is heart disease. That's globally, but it definitely is true for South Asians. And that's not going to change. You know, we've already talked about why we are already predisposed to having issues with higher risk for cardiovascular disease. And that still rings true with glucose control issues, diabetes, pre-diabetes, insulin resistance is through the roof. So again, physically and metabolically, we face some of the most challenging cardiometabolic risk profiles of any ethnicities. And we've already talked about that. We have famine-adapted biology. We have adipokine dysfunction, and this will be talked about as I continue to progress through this slide set of what's actually been looked at in the literature. We have an incredible amount of insulin resistance that's predisposed to us, but a lot of our lifestyle factors, a lot of our habits do not do anything to reverse that. And it is all completely reversible. Every single one of these chronic diseases is absolutely controllable and reversible. So don't let anybody else tell you that that isn't true. I've done it. You know, certain aspects of myself, I've done it for my Indian clients. And a lot of these Indian clients are doctors of a variety of different backgrounds. You know, we have low lean body mass and a high amount of cardiovascular risk. And again, we do depose a significant amount of visceral fat, and anything above 250 grams is associated with higher all-cause mortality. And a lot of this stuff is already published in the literature. So everything that I've put together in all these slides, I've done massive deep dives into what has been published on South Asian. Though I haven't picked every single study because there are a lot, you know, but when it comes to the breadth of literature, we only make a very small percentage of what actually gets published and shared online. So most people, if you do have a South Asian background, you probably haven't come across much of this, but you should be known because if you put your hands into the average healthcare practitioner, especially if they're practicing Western medicine, it's over for you. They're not going to be able to do that very much for you. You know, they're going to spend their 15 minutes with you. They're going to look at your data. They may or may not have a strong association with understanding why are you the way that you are and what can you do about it. And or they're going to look at individual metrics, individual biomarkers in isolation without any context and see something along the lines of, oh, your fasting glucose is a little bit high, your A1C is creeping up, but we haven't gotten a fasted insulin. So ultimately, we already know you're insulin resistant. Your home IR is probably over 3. But your triglycerides are high, your HDL is low, your LDL might be high, and total cholesterol is high. So, okay, what are we going to do? We're going to put you on a statin, and we're going to put you on metformin without actually figuring out what is it that you can do that's within your control to take positive steps to moving in that right direction. Because the second you even just start taking the medication, yeah, it'll lower those specific markers, but it's not going to fix the underlying problem. And you're still going to be at risk to continue to be insulin resistant and to continue to drive your risk factors for actually getting these chronic diseases through the roof, independent of, oh, your LDL happened to go down a little bit, but you're still a fucking mess. And that's what you need to realize. So, had a little bit of a masterclass on genetics, but we'll talk a little bit more on that stuff that's already been talked about. But now we see it within published articles, you know, epidemiology, a few other things. We already know for any given BMI, South Asians tend to have more body fat, especially around the abdomen area. We talked about the importance of looking at and measuring visceral fat. And if you don't want to get a DEXA, then just go get waist circumference done because it's going to tell you something very similar to what you may or may not already know. So having more fat in and around the midsection plays a huge role and contributes to the high susceptibility of metabolic syndrome within the South Asian population. So thousands of years of famine, and this doesn't just go back to when we were under British colonial rule. We're talking about thousands of years of famine. They've influenced death rates, you know, that's gone up, food availability, which then influences epigenetic factors that rear themselves when people are living the way that they are, how our bodies have had to adapt metabolically. We talked about that in the last video. If you haven't seen it, go check it out. It's really good. And why our bodies are the way that they are. Again, this doesn't mean you can't put on muscle mass. This doesn't mean you can't lose body fat. This doesn't mean you can't get strong. You absolutely can. But when we're talking about all of us in general as a whole, we have to work a little bit harder. And that's why, yeah, you will get outliers. There are outliers in every single population on the planet. Even in very dire and poor circumstances with access to very little resources and hope, you do get amazing outliers. And that's just common amongst any population group, you know, within a population throughout timeline of humanity. But when we look at all of us as a whole, the data do not support what we would think of as, oh, I had a friend who was able to bench X, Y, and Z, or who could do this, or put on, like, look, if you look at it globally, what South Asian athletes are dominating all over the board. Certain sports, yes, but there's nobody here in North America because you're getting thrashed by everybody else. Because, again, you have to be very intentional about what you do when it comes to training. And I'm going to be hugely an advocate for us, but at the same time, you have to be your biggest fan, but also your harshest critic, and understand this is the reality of our situation. If you keep dicking around and getting pats on the back and thinking everything's okay, you're never really going to get the outcome that you want. And I've been there at the top. I've worked with the best of the best. I know what I'm talking about. So, continuing on, South Asians have low lean tissue mass relative to height. We already know this. Basically, it doesn't matter how tall you are. We still have smaller frame sizes, lower amount of bone mineral density, and less muscle mass. Not just lean body mass, but less muscle mass. So with less muscle mass, there is less glucose disposal directly at the muscle, which does negatively influence the ability to use glucose, especially if you're not moving around or exercising, which is not very common amongst the South Asian population contingent. Especially, my generation and older, it has never really been a priority. The younger kids get it. They're doing a lot more. They're, especially if you're second generation born here in the States, these kids are much more athletic. Their access to resources is greater. Their nutrition quality is a little bit more diverse. Still a lot of work to be done there, but they are becoming more and more effective playing a variety of different sports. So it's not just the long torso, long limb sports, the tennis, the badminton, field hockey that we can dominate. We're starting to see some incredible progression in a variety of others. So again, this is talking about the elevated adiposity, not only regionally across the stomach, but overall throughout the entire body. And the BMI isn't very elevated because muscle mass is down. So there's that crossover. Skeletal mass is down, muscle mass is down, fat mass is up, but you don't end up getting to see it with the number on the scale unless you go and get your body composition done. So that's why I'm a huge advocate of just go and get a DEXA done. You don't know how many clients that come to me with their DEXAs. They get their information because obviously I'm assessing everything, and they get very humbled by it. And they're like, I did not realize this is how fat I was and this is how little muscle mass I have. I'm like, you and everybody else, but there's something you can do about it. The better, it doesn't matter where you start, when you start, it matters that you did start. But when we look at adipokines, leptin, which is strongly associated with adiposity, is elevated in South Asian bodies. Adiponectin, which is what we want a high amount of, is attenuated by these metabolic variables that ends up getting driven down in South Asian bodies. So the Masala study was great looking at it. Again, this is looking at the data and having it explain not only why are we the way we are, what is it showing, and being empowered to learn more about what's going on underneath the hood is very, very important. So general findings with body composition: more total body, subcutaneous and visceral, and hepatic fat than really any other group on the planet. Greater intramuscular fat, less lean mass, less muscle mass. Let's just think of lean mass as muscle and bone for the most part. Greater visceral and pericardial fat. That's not good. Lower adiponectin, which we want higher. Higher resistin versus all other ethnic groups. All this stuff has been published and studied. A high amount of fat to lean mass, which you actually want at the opposite, highest of any ethnicity. And the thin fat phenotype, I've already talked about this, it's the South Asian phenotype, which means at very, very normal BMIs, you have a higher amount of fat mass, lower amount of muscle mass. So BMI is not a good indicator of you understanding, am I healthy at a good body weight? The body weight is independent of anything. It has to be body composition by far and away. So this kind of already talks about everything that I've already mentioned. We know adiponectin is higher in Europeans than us. Leptin is higher in South Asians than Europeans. HOMA-IR increase per unit. Decrease in adiponectin was larger in South Asians. So obviously you want a lower HOMA-IR. The calculation for HOMA-IR is fasting glucose times insulin divided by 405. So obviously the lower your fasting glucose, the lower your insulin, the lower your HOMA-IR. But most doctors, even on your annual physical, they won't look at insulin. And standard reference ranges are an absolute disaster. Everything comes from Quest and LabCorp, mainly Quest. They are the largest biomarker lab in the United States. They have their reference ranges. They're just comparing you versus everybody else. If 93% or even greater, I would say 95 to 98% of Americans are just unhealthy. And you have to have an appropriate definition of what health is, and I have it. I use it within my practice, I use it within my business, with the people I work with, so I can quantify if somebody is or not. You're comparing your results to everybody else. So if you're normal within a reference range of an unhealthy population, is that exactly where you want to be? No. So yes, you would want to get if you're South Asian, you want to get your insulin levels definitely below 6, ideally potentially below 5 or 4, but not only that, you want your HOMA-IR score below 1.0. Mine's 0.8, and it's been like that for 6 years. And it's independent of carbohydrate intake. So again, the carbohydrate and insulin model, that's bullshit. South Asians have the least favorable adipokine profile globally. Again, you can check out any of the studies that I'm looking at referencing and talking about right here. We've got the PMIDs, we've got the title, and all that. Our phenotype, high fat mass, low lean mass. South Asian men and women have less lean mass than all other ethnic groups. Fat to lean mass ratio is higher in South Asians compared with all other groups. Again, this is what's published. This is in the data, and this is reality. Again, it doesn't mean you can't put on muscle mass. They've done studies, not a lot, but they've done a couple studies, 12-week studies of, South Asians around a younger age, around your 20 years old. They go through 12 weeks of resistance training, and so do a variety of other ethnic groups. And what they found is South Asians can stimulate muscle protein synthesis in the same regard as those others. We can put on muscle mass at the same rate as those other groups, but the only caveat that comes in here is we already know what our predispositions are when it comes to our bodies metabolically and physically. So the South Asians were the only group to put on fat mass, and we had unfavorable changes in glucose control. So you want to talk about a humongous kick in the dick. You start executing a resistance training program, which is the basis for every South Asian, regardless of age. That's what you have to start with. That's the number one thing you need to do. It doesn't mean it ends there, but if you're going to figure I only have 3 days a week to work out, resistance training is the number one thing you need to do and should do. But as you put on muscle mass, if you're not controlling your nutrition, if you're not addressing movement, if you're not controlling self-care, stress adaptation, understanding, nervous system physiology, and sleeping really well, then you might not get the favorable changes that you'd want. So yeah, you can put on muscle mass, but putting on fat mass and having issues arise with glucose control is not what you want to see. So there you have it. You want to, and I have people, social media, arguing with me, talking. I'm like, nobody on the planet knows South Asian physiology better than me. I'll put my knowledge up against anybody in the world. Look who I've worked with. Just look at my results. Come on, man. Cardiovascular disease. So there's a huge global burden for cardiovascular disease in South Asians. We make up 25% of the world's population. 50% of the atherosclerotic cardiovascular disease events globally occur in our group. So you want to tell me one of the biggest things that we need to address? And generally, there are things that are going to happen and present prior to the cardiac events happening. It's insulin resistance, leading to unfavorable metabolic changes, which could also include elevated blood pressure and oxidative stress, which leads to calcification, glucose control issues, which happen for an extended period of time that do not get addressed because insulin sometimes doesn't get looked at in people that are 20, 30, 40 years old. And then the issues start arising. It's not, my LDL's only been elevated for a year, I'm going to get cardiovascular disease. It's like your insulin has been elevated for 15 years and nobody's told you about it. That's the first step. That's what needs to be addressed first and foremost. Because cardiovascular disease does not automatically happen. It's uncontrolled, unchecked things when it comes to your metabolic health, which lead to this. It's one of the biggest issues here in modern medicine. They just released new cholesterol guidelines, and I think it's brilliant talking about certain ethnic groups, certain populations having to have more defined targets, but throwing everybody on medication without understanding what drives the cardiovascular events is asinine. And I've had cardiologists as clients, and they've improved their lipids, their labs, pretty much every marker that we look at, independent of having to deal with anything medication. My goal is to never have a client get on any medication. So earlier onset, the cardiovascular disease events happen earlier within our population than other populations. As early as 10 years prior. It's more aggressive and we have worse outcomes. There's higher mortality and equivalent risk scores, which means the way we screen and the way we measure needs to happen at an earlier age. It's under-recognized. What they use for calculating Western, risk scores don't meet the needs for us. I told you Western medicine is a disaster for South Asians. It's insulin resistance driven, so excess risk largely from insulin resistance related factors. So we've already talked about that South Asian skinny fat phenotype. High glucose, low HDL, high triglycerides at a normal body weight. I mean, that's a really easy thing to look at for your metabolic health. If you don't have a laundry list of labs, you can look at your triglyceride to HDL ratio. It should be less than 2. Mine's 1-to-1. Probably about like 65 for each. And within our ethnic group, within our population, it's not true for all ethnic groups. It really doesn't hold true for African Americans because they can have someone can present with a really favorable triglyceride to HDL ratio, but they can have a very, very high insulin score. Generally, you don't see this in Indians. If your triglyceride to HDL ratio is really, really good, I don't think I've ever seen anybody that's had a poor insulin score or a poor HOMA-IR score. So even in our healthy BMI range, we have dysglycemia and dyslipidemia, 25% more than other populations. We're 5 to 9 times more likely to exhibit dysglycemia or glucose control issues and dyslipidemia within those healthy BMI ranges than any other U.S. ethnic group. So again, throw BMI out, go get your body composition done. Go get a DEXA done. It's easy. It's not hard. High subclinical coronary atherosclerosis explains our high cardiovascular disease rates. High prevalence of diabetes, abdominal obesity, hypertension, often under-recognized. Especially when you go to the doctor's office and they don't follow standardized protocols for getting a blood pressure on you. Ideally you'd want to be sitting with your back supported for about 3 minutes or so, very calm, not dehydrated, not overly stressed, not having just run up a flight of stairs to get to your appointment and then get your measurement done. Now, the unfortunate thing is you're in the system that likes to churn people in and out. So they'll get your vital signs, your biomarkers, but it's not in the appropriate situation and circumstance or setting. So it may be done right or it may be done wrong. And then they're misinterpreting the data and then telling you, oh, you're pre-hypertensive or you're hypertensive, we'll cut out salt. Well, that doesn't fix anything. Again, you're looking at one marker in isolation without understanding the physiology behind it. So screening, risk factors, this just talks about higher proportional atherosclerotic cardiovascular disease. We already know that. Highest rates of CAD in Canada. So it's not just limited to one country. It's all over the globe. We already talked about that. The scary thing here is there's an earlier onset. You know countless number of Indians that I've talked to within my generation. I'm going to be 41 next month. People in their 30s and 40s say, we've got a family friend. I've got a friend. I've got a cousin. I've got a close family member that just passed away, and we didn't know about it. It was heart disease. It was a heart attack. It was a stroke. This stuff is happening earlier and earlier. So before, we would really only worry about this with our older family members that were in their 60s, 70s, and 80s and beyond if they made it that far. But now this is happening much earlier, and again, there's a reason for it. You got to do something about it. You got to take care of yourself. 50% population attributable risk for dyslipidemia for myocardial infarction. It's a pattern. Lower LDL, but higher triglycerides, lower HDL. When we look at labs, we want to get the full-on everything. You want to look at ApoB, LPA. We want to look at particle size. So it's not just about LDL. It's how many of these particles, are they small? Are they medium? Are they dense? Do you have A pattern? Do you have B pattern? You know what I'm saying? You want to look at everything. High ApoB and elevated LPA, that's a disaster. You throw very, very high insulin, staying elevated for a very, very long time, that's an even bigger disaster. So, atherosclerotic cardiovascular disease risk factor profile among U.S. South Asians. You can check that out. It's very, very high. The Diwali study, which recently came out, which is great. It just talks about prevalence. and risk factors. Check it out if you want to. A lot of this stuff is saying the same thing, and everything is connected. And everything makes complete and utter sense. When we look at pathophysiology of why this happens at earlier ages, the first thing that'll generally always pop up is insulin resistance. Yes, genetics, but we can't do anything about our genetics in terms of, we're predisposed to this. You can control diet, you can control activity, which can help drive down visceral adiposity. And we can increase the appropriate adipokines that we want to have a more favorable profile of dropping down resistin, dropping down leptin, and driving up adiponectin. And a lot of that stuff can be tested now on labs. You go to a MitoHealth test, you throw that on there, function, all these other places they're testing for it because it makes sense, especially within our population. Being South Asian is recognized as a risk factor. I wouldn't worry too much about cholesterol in a vacuum. There are other things that are more important. Another thing that can be looked at, you can look at CAC or CCTA. CAC measures volume and density, and it looks at coronary artery calcification. So HDL is directly associated with CAC density. Waist circumference inversely associated with CAC density. BMI, hypertension, diabetes, HOMA-IR directly associated with CAC volume. So we should stop and just listen to that again. Blood pressure, how fat you are and how much muscle mass you don't have, your glucose control, and how much insulin is your body producing is directly associated, and this isn't even talking about anything lipid-wise, with the volume of calcification within your arteries. As I said before, the number one thing you want to be aware of is insulin resistance. That drives almost everything. And it's also a good indicator if you look down the line of a bunch of different biomarkers. There's probably a tremendous amount of systemic inflammation going on. You probably have issues with glycation within the arteries or the quality of the arteries. You could look at homocysteine. We could look at systemic inflammation with high-sensitivity CRP. You can look at your omega-6 to 3 ratio, 3% index. Uric acid levels are likely high. You can see dysfunction all over the board, and it's not individual to one marker or one system. It's going to be happening in a variety of different areas. So what's unique in terms of if you get a CAC, what about calcification within the South Asian population? Well, South Asian men have a similar CAC burden to white men, but higher than all other racial or ethnic groups. So we're still up there. South Asian women, similar to other women, but higher CAC in older age. So I just got a CAC done probably about 1 or 2 months ago. My score is 0. So the thing that you're only going to get using a CAC is if you have any hard plaque. If there's any soft plaque, it won't pick up. That's what a CCTA is for. But South Asians have more dense plaque and it's hard. We generally don't pose with a lot of soft plaque. So if you are going to get it done and looked at, you can start with the CAC. But if you do want to dive a little deeper, a CCTA is definitely warranted, I think, especially if you present with having hypertension, you have glucose control issues, you have HOMA-IR. You just kind of check the box of disaster all across the board, and you present with metabolic syndrome too. So as I said before, CAC volume is lower in South Asians, but density is higher. So we have more density and it is hard compared to volume. Volume is higher and it's soft. So understanding that is important too. Some more risk factors. This just shows genetic predisposition, lifestyle factors equals high prevalence of all these issues. Everything is reversible and controllable. You can pause and take a look at this stuff. Hypertension, look, we're predisposed to this. This was talked about before in the previous video. It's just more aggressive path in us. 3 times likely to be hypertensive at a younger age than European whites. Prevalence is well over 1/3, which holds true in a variety of different places all over the globe. Age adjusted, you have got comorbidities. So yeah, if you're South Asian, you're likely presenting with insulin resistance, and you might have some glucose control issues. You probably have hypertension too, or pre-hypertension. Having hypertension, strong correlation with increased abdominal adiposity. and it's vice versa. It's chicken or the egg situation there. 2 to 5 times higher risk of developing type 2 diabetes compared to people of other ethnic descent, which enters right into here. Higher prevalence and earlier onset of type 2 diabetes and atherosclerotic cardiovascular disease. Any other race group, the Masala study showed this. So lower insulin secretion, kind of already talked about that from a genetic perspective, more insulin resistance, poor body composition. You might have beta cell dysfunction. Either the cells have been churning out too much and they've been shut off, or at birth you had dysfunction to begin with and you are not able to secrete as much as you need to. Drivers of this, remember, I talked about this: low adiponectin, high visceral fat in and around the midsection, lower beta cell function, and then controllable lifestyle factors: sedentary lifestyle, very, very poor nutrition, which is very standard within the culture of what's typical of a South Asian diet. Now we're getting diagnosed with both of these, not only type 2 diabetes, but cardiovascular disease at younger ages. High, small, dense LDL. So you don't want a high amount of small, dense particles because they're the ones that can get oxidized at a much faster rate than the larger particles if you have less of those. You've got higher triglyceride, lower HDL, elevated LPA, ApoB is high, which is kind of like your full-on LDL cholesterol snapshot, which is better just to look at versus just looking at LDL or total cholesterol, which isn't, and again, in isolation, you don't want to make any snap judgments or decisions without getting the full picture. And again, the biggest thing to address, the only thing we can address, your environment and your standard behaviors and habits. This is just telling us what we already know. South Asian countries experiencing rapid increase in overweight and obesity. In any other region in Asia, higher body fat percentage at the same BMI, lower resting energy expenditure. And this is a big issue. I talked about it before in the previous video, but this is a massive issue, which leads to unfavorable changes in body composition over time. So this is one of my favorite diagrams, and this comes from this study, Energy Metabolism in Relation to Diet and Physical Activity, a South Asian Perspective. So I think if I were to highlight one single thing, which means the most out of this entire video, it is this, where, yes, the reality is we have a genetic predisposition to obesity because of what our ancestors had to face for thousands of years in terms of famine, in terms of our habits and our lifestyle, in terms of survival in that part of the world. So with smaller frames, lower muscle mass, just basically surviving through the famines, that's how our body's adapted. Doesn't mean you can't get big and strong. You can. But this is what the reality is of what we're predisposed to for the most part. You have a predisposition to obesity because you have lower muscle mass, skeletal mass, and a higher amount of body fat to start with, which leads to lower resting energy expenditure, just in terms of your body physiologically. If we're going to calculate your RMR, your resting metabolic rate, obviously having more muscle mass and less fat mass, and even a higher body mass leads to a higher resting energy expenditure. So if I were to take a South Asian man who's 170 pounds at 30% body fat, and a Caucasian who's 170 pounds and 20% body fat, everything else kept the same, the Caucasian man who has more muscle mass is going to have a higher resting energy expenditure. So when you burn less calories than you take in, you're at a caloric surplus. You're going to put on fat. Standard equation. Coupled that, controllable lifestyle factors are right here. What you eat. If you eat a lot of poor food and you eat more than what your body is burning or expending because you also have a low physical activity level, you don't get very many steps during the day, and or you don't exercise, you don't resistance train to put on muscle mass, and or you don't do aerobic training to drive up mitochondrial number and density to help with lactate clearance, to help with increasing intra-exercise energy expenditure, you're not going to burn any calories. So over time, you get an unfavorable shift in body composition. You're in this positive energy balance, caloric surplus. Well, what does that mean? Well, for my athletes, that's cool. You put on muscle mass that way, as long as the positive energy balance isn't significant. So you gain fat. You continue to gain fat. Well, yeah, you're going to continue to put on more body fat. It's going to distribute centrally. Remember what I told you? Yes, it can be subcutaneously. It can be within the muscle, but for the most part, it's because we've got longer torsos compared to our lower limbs. Done plenty of measures on thousands of people, athletes, elite and not, to conclude this, and even myself. You're going to start storing it centrally. It's going to go to places, we don't have very large appendages, very large arms. You see people with just a crap ton of fat stored in their arms and legs. We don't have that surface area or volume there. So it all goes centrally. You see that, large, older Indian male pot belly. And now it's happening at younger ages. People in their 20s and 30s are storing it because at younger ages, their habits are getting worse and worse and worse. So central fat storage, again, we've already talked about how pro-inflammatory that is. That's going to lead to issues within the body, dyslipidemia, insulin resistance, number one, glucose intolerance, and that's going to cause a lot of issues down the line if you don't do anything about it. We also have high prevalence of vitamin D deficiencies. Obviously, the darker skin you have, the less UVB you're going to be able to absorb from the sun, even if you spend a lot of time outdoors. And this holds true with, a lot of the elite athletes that I've worked with that live in places like Texas that train for hours at a time, not wearing a shirt, and their darker skin, their vitamin Ds present, 7, 11, 19, 17. Like, you can't, if you have darker skin, if your body doesn't utilize and metabolize it appropriately or very well, like, you have to supplement. And it's not just getting to 30, which is what a lot of the world organizations think is good enough. That's not good enough. You want me to tell you what my ideal ranges are? You're going to need to bump yourself up to about 60 or 70. Last time I checked, mine was like 71. I supplement. I try to spend as much time outside in the sun as I can, but I'm not going to absorb as much. Sunlight is good, but for us, it's not going to move the needle on vitamin D. So vitamin D deficiency is obviously ends up being very, very prevalent with a significant amount of obesity and high amount of adiposity. It is linked to increased cardiovascular disease, diabetes risk. Again, muscle function and control, immunity, everything. Associated with higher systolic and diastolic blood pressure and fasting glucose. Metabolism may differ by fat distribution in South Asians. So again, it's something that needs to be addressed. And vitamin D is an easy marker that you can throw on any panel. And don't expect your doctor to do it. Go ahead and get a panel yourself from a company like Mito Health. Our C-reactive protein is significantly greater in our population. So again, that's something to look at on blood work. Most people would say the ideal range is below 1. For us, I think it's below 0.7. I range around 0.2 and 0.3 every time I get tested. Obviously, if you're going through an intense training block, inflammation is going to be present. If you end up getting sick, body's going to be fighting the infection, inflammation is going to be present. That's okay. But if you feel like, I'm totally normal, I'm not fighting an infection, you get a result and it's 3 or greater or 2 or greater, yeah, your body has an excessive amount of inflammation going through. And that's pretty common with a lot of the South Asian people that I work with and see. And the reason is central obesity, the adiposity, high amount of visceral fat. That's a key promoter of low-grade chronic inflammation, not just in South Asians, but in everybody. But again, we tend to have a significant amount. So understanding, not only what are my numbers and what is driving it, is it because I have an excessive amount of adipose tissue in and around the midsection? Okay, go assess what your visceral fat numbers are. You can get that from a DEXA. It's not the only way, but it is the best way and probably the easiest way to do that. Again, this is kind of beating a dead horse. High prevalence of abdominal obesity, more intra-abdominal and truncal subcutaneous adiposity in Caucasians. So if you've seen the standard Indian body, even for some of these teenagers, these 20-year-old men, it's not much chest definition, these really long arms. And I've got the long arms too. I have a massive wingspan. I got to deal with it as well. And as the body goes down from the chest down to the waist, you see there's a lot of fat storage. They've got the love handles that kind of flip out. You might not have this big pot belly yet, but it's going to get there. And again, it's physiologically because of not only our dimensions, but internal environment and what we've had to deal with from an evolutionary perspective, it just gets thrown on in there. So it's the first place that it gets deposited. It's the last place you're going to lose it. So you can do it if you know exactly what to do and you're consistent with it, but you do have to work hard. And that can drive higher insulin resistance too. So here's another this is the number 2 best diagram that I've pulled from all of these resources. So obesity and dyslipidemia in South Asians, this is the diagram, the pathophysiology. So number 1, where do we come from? Perinatal factors, maternal, neonatal, childhood adiposity. What is it that we're dealing with from a predisposition standpoint? Our abnormal body composition. We already know this. Low skeletal mass, low amount of muscle mass and lean mass, higher amount of fat mass, especially in and around the trunk, the abdomen, which shows that it's a high amount of visceral mass. It has an unfavorable adipokine profile. It is constantly secreting inflammatory cytokines, and it's not good. And then you take in controllable lifestyle factors. Overall, we've compared to our expenditure, we have a high energy and fat intake, really a lot more refined carbs, very low in protein and fiber. Micronutrient intake is poor. The omega-3 status is very, very poor. Vitamin D is low. Magnesium's low. Zinc is low. I mean, I could run the whole gamut. Iron too. And again, what that does is, without the appropriate substrate internally to let the body operate the way that it needs to, for methylation, for detoxification, for ATP production, for glucose control, for nervous system function and development, everything. Internally, we do start seeing decreased insulin sensitivity. We're obviously predisposed to this, but having an excessive amount of body fat in and around the trunk does, like I said, secrete pro-inflammatory cytokines, which can lead to CRP. We just talked about that in the previous slide. This also has a negative effect when you have decreased insulin sensitivity. So when you eat poorly and you store body fat and you don't do anything to expend energy, you have glucose control issues, which start controlling type 2 diabetes. You have decreased insulin sensitivity because you're not training and clearing out that stuff. You're constantly stressed in this environment. The body is responding to cortisol, being sympathetically activated. It's everything in your environment. Poor sleep, no exercise, constantly being stressed all the time. And, internally, within the blood, you've got high free fatty acids, which store in the liver, can be in the muscle, but essentially it's going to store in and around the organs, as we talked about here, which, again, can be exacerbated to present with hypertension, dyslipidemia. And all of these things in the background, slowly over time, are accelerating this. This is the end stage, heart disease. So you don't freak out about heart disease first. You look at the mechanism of why it could potentially be happening. What kind of data do you have? What objective and subjective data do you have? And the fix isn't hard if you know what you're doing. Most people don't know what they're doing. So metabolic syndrome, it's a big issue. It's happening now at younger ages. It's manifesting earlier and earlier, even in childhood, which is sad. That hurts me to the core, having 2 kids at the house, young kids. Putting them through that, and that's on us. That's on the older population, the older generation. It's not on the kids. Kids don't know any better. They're kids. What do they know? Nothing about this stuff. But we should, as the people in charge, as the grown-ups in the room, should be armed with this information. Because if you don't have health, you don't have anything. No matter how fucking rich you are. No matter what trips you take. You don't have health, you don't have anything. Metabolic syndrome and cardiovascular risk factors in South Asians is hidden by, we can look at what metabolic syndrome looks at. It looks at triglycerides, it looks at HDL, it looks at fasting glucose, it looks at waist circumference, and it looks at blood pressure. Everybody checks that box of what they present with, even if we tighten those ranges, because we need to be a little bit more isolated and intentional about controlling those ranges. And even if you tighten them up, that makes it even worse, because most South Asians are not going to fall within those categories too, of making sure that they are where they need to be. So if you check the boxes of all those 5 things that I talked about, more likely you're going to have higher body fat in and around the midsection. Cardiovascular risk factor happens now at lower levels of adiposity within the South Asian population. They've lowered BMI and waist circumference cutoffs. As I said, you can't just use the standard metabolic criteria. And when you end up doing that, you see that these cardiometabolic events, mainly more metabolic, leading to cardiometabolic events, are happening at an earlier age within the population. Again, it's driven by Your environment where you live, poor nutrition, not doing anything, legitimately not doing anything. Look, your walk around the block, that's great. It isn't doing shit. Your yoga that you do once a day, once a week, that's not doing anything. On top of, yes, we have a genetic predisposition. I already covered it in the last video. Abdominal obesity is the single most important risk factor for metabolic syndrome and type 2 diabetes. Waist circumference and or get a DEXA. Understand how much visceral fat you have. Coming up here right before my birthday, I'm going to get another DEXA done. I'm going to show everybody what it looks like and how you read it. How can you interpret it? And it's not just getting the data, it's interpreting it and being informed by it and then driving your decisions based on that and understanding context around somebody's life. To prevent obesity, metabolic syndrome, and type 2 diabetes within our population, look, one is just being aware of where you are at. What do all these different areas look like? Getting a good amount of objective and subjective data within what are you doing from a diet and physical activity and movement standpoint? What are you doing from a recovery and self-care standpoint? To me, considering pharmacotherapy, and this is coming from this paper, like, you don't need to do this. You need to have structured strategies that are sustainable, that you can fit within your life. But at the same time, you just can't expect to go through the motions and say, well, I'm walking a little bit more. I'm kind of making some nutritional changes, because we're so far behind the 8 ball. You have to work harder and be more on point than any other group to reverse some of these issues because of our genetic predispositions and where we currently stand. Even if you implement normal guidelines, you might get half of the results as somebody else following them. That's why you can't believe what a lot of these talking heads, these influencers are saying, because they don't know any of this stuff. They're all full of shit. So fitness, strength, physical activity, this is also very unfavorable for us, but understanding the data and being self-aware is the first step. Doing something about it is the next. So some of the easiest ways to quantify strength is, doing a hand grip, using a hand grip dynamometer, doing a leg press, easy things that you can administer throughout a variety of different populations. So take it for a grain of salt, but it also is pretty true if we think about it. Globally, we have the lowest hand grip strength. How do you measure hand grip strength? Hand grip dynamometer. And, people talk about it, it's correlated to longevity. Well, people that generally work out, even if you don't have like Shaq hands, they're going to have a higher grip strength than people who don't work out. People who don't work out or take care of themselves, they're going to fucking die before everybody else. That's pretty obvious. You get what I'm saying? Or you're going to live a very poor quality of life within the last 5 to 10 years, after retirement. Because you're supposed to ride off in the sunset, but it's the worst years of your life because you have no vitality. So the highest grip strength values come from Europe and North America, and they have reference ranges. So I do this every now and then. Again, my grip strength is, for my age, is in the elite category. It's around 120 to 130. That's in pounds. And I don't have very big hands. I'm a 5'9", 5'10" Indian dude with a small frame. So being realistic about that is fine. But a simple test that can be done. And the fun thing is, I've had some clients buy one and, they have it as a party trick, within their families, within their friend groups, who can get the highest, and they make a competition out of it. Okay, how do you get higher grip strength? Well, spend some time in the gym getting stronger. So 3 to 4 times higher diabetes prevalence in South Asians versus white Europeans across all grip strength levels. 5 to 6 kilogram lower grip strength in our men and women versus other ethnic groups. So this just shows low strength equals substantially more diabetes, which, the more muscle mass you have, the stronger you are. The more muscle mass you have and the more you use your body, the more glucose you're going to end up hopefully disposing, which leads to holding off diabetes and maintaining your glycemic index in the appropriate range. So this also was a test looking at exercise capacity, skeletal muscle function in older adults, lower strength, South Asians versus Europeans, reduced exercise capacity, South Asians versus Europeans. So what this is saying, we are weaker and we are less trained in terms of just the average people we are plucking from the population, which there's no surprise there, understanding what our general habits are and our attitudes towards prioritizing health, wellness, and fitness and exercise. Nothing strong there, nothing groundbreaking. This was a really interesting study too. When we look at, should physical activity recommendations be ethnicity specific? The answer is yes. So the evidence from a cross-sectional study of South Asian and European men. So what's typically recommended is about 150 minutes per week of moderate to vigorous physical activity. And moderate to vigorous is relative. For people that don't work out, this is like going on a brisk walk, because we use either METs or you can use heart rate response to that exercise. Now, if you are untrained, detrained, you don't do very much. It doesn't take much of doing some kind of consistent form of exercise to elevate your heart rate to that moderate to vigorous physical activity. So what's moderate to vigorous to me is going to be way higher than what's moderate to vigorous to anybody else, because again, everything is relative. So 150 minutes per week is kind of the catch-all for the average European, white person here in America. To get the same cardiometabolic benefit, South Asians need to do 266 minutes. As I said before, we have to work harder to get the same results. That's about 1.5 times more. So everybody talks about, step count. This was very similar. So they talk about, cardiometabolic risk score, doing 150 minutes a week. This one's 232 minutes. So it's an extra 10 to 15 minutes of moderate intensity physical activity per day. So 10 times 7 is 70, 15 times 7 is 95. So it's basically another hour and a half per week to do what other people end up doing in an hour and a half less. As I said before, we have to work harder to get the same results. Now, what does physical activity look like within our populations? So it's going to be variable. So almost 20 to 88% are inactive. And this is the important thing. This is like, I work hard, I do X, Y, and Z, but everybody gets some leisure time. Is it the weekend? Is it some time during the day? Do you allocate something when you're not working or studying or, taking care of the family? That's when you have your open time and your leisure time. What is it that you're doing? Well, most South Asian adults are inactive during their leisure time. So there's no prioritization of physical activity, of taking care of your body, of getting stronger, of getting fitter, of making sure that you are pushing away thousands of years of horrible predisposition genetics and everything that's been talked about up until this point in this lecture, in this video, about what are we seeing within the data of what an average South Asian person looks like based on what the studies show. And what the studies show is we're in bad shape. Very, very bad shape. More data of what do we see the average South Asian person doing. Protein intake is very low. Only 6 to 8% of calories in South Asian diets versus 29. There's this Eat Lancet reference, so this hasn't been studied wholeheartedly, but you can just look at not only what you might be doing or what family members are doing, what older family members or friends are doing, and is this right? Because I think the catch-22 is South Asian culture is very supportive of making sure everybody has everything that they need. We have great family gatherings. We have, memories. Everything sometimes is built around food. It brings families together. It's a part of some of the biggest events, weddings and graduations and, holidays and X, Y, and Z, which is great. But at the same time, it's a lot of the things that are negatively holding us back when it comes to pushing us forward and getting healthier. And that just gets compounded. This is what I normally do. I wake up, I have this nasta or this chai, or I have just a bunch of carbohydrates. I don't eat very much for breakfast. I don't, eat a lot for lunch. We have a big dinner, but there's no protein involved. I haven't done any movement, haven't done any resistance training. And then we do it again. And that's what we associate as, family time, cultural time, eating those foods that our older family members, our ancestors have done for a very, very long time. In reality, that's just not gotten us positively moving in the direction. Doesn't mean we abandon it completely. It means, okay, I have to be a little bit more mindful about how I craft the way I eat. And what am I getting? Even the richest households in South Asia do not consume an adequate amount of fruits, vegetables, and non-cereal proteins. Doesn't mean you got to start eating meat if you're vegetarian. No, that's not what I'm saying. It's just South Asian diets across income groups, across the globe, is unhealthy. And if you don't think it is, this data proves it. There are a lot of these people that are talking out of their ass in India, these uneducated people, even people in the medical field. Like, you don't know anything. You don't know anything. It's embarrassing. Excess cereals, not enough protein, fruits and vegetables, not enough fiber, not enough omega 3s. I mean, the data proves it. Look, this talks more about the Eat Lancet reference diet. So, vegetable and fruit intake is atrocious everywhere. Protein intake, this is the reference, these are Indians. And it doesn't mean like, look, you have to eat meat, but for the most part, that's the highest quality protein source that you're going to get. It's low. Look how low that is. It's atrocious. Caloric share by food group. This is that same study. So, number one, South Asian diets are protein deficient. There is nothing you can say that goes against that. The data supports it. Common sense supports it. Just open up your eyes. That supports it. So, if we look at the recommended 60 grams a day, which is too low, that is, I get 60 in one meal. I eat 4 meals a day. That's low. 70-80% of caloric intake comes from carbohydrates. And it's not high quality carbohydrates, fibrous carbohydrates, it's refined. Because now ultra processed food is all over. Everybody eats it. If you look at intake, rural and urban, it's down. It's down since 93, 94. Almost 20 years ago. It's down 30 years ago, which is awful. So I'll tell you, what they say is you only need about 0.6 grams per kilogram of body weight. This was made up from bad information. This is a minimum amount to stave off sarcopenia. And even in our population, if you understand the genetic component behind it and sequencing some of those SNPs, this is still far too low. Some say it's around 0.8 gram per kilogram. You need to double that. The minimum amount an Indian needs to eat should be around 1.6 grams per kilogram, or about 0.8 grams per pound body weight. And potentially you can eat even more. So, South Asians are deficient. Most have no clue how much you need. Or you're like, oh, my doctor says I only need that. Why are you listening to these media outlets and doctors about what you need? They're unhealthy too. They have no clue what they're talking about. Global average, 68 grams a day, still too low. Even in America, the average American man is about 5'9", 5'8", 5'9", 200 pounds, probably around 30% body fat, 25 to 30% body fat, which is brutally unhealthy. Average intake in America is around 100 to 110 grams. Still too low. Still way too low. Average South Asians eating around 47 grams per day, lowest globally. And look at our strength and fitness stats. Look at our glucose control stats. Look at our cardiovascular risk factor stats. We're the worst in the world. This is a big issue for it. 71% of South Asians, 30 to 55, have poor muscle health. 68% have low protein diets. Not just poor muscle health, but just strength. It's embarrassing. It's bad. If you want to look at protein consumption across the globe, India is low. America's a little bit higher. It talked about 90 grams or so. Indians are barely over 50. Protein consumption per year in kilograms per person. Generally the United States. India's right here. It's pretty bad. So this is just a general summary of everything that's been shown in the literature of why are we the way we are and why are we so in such poor health, physically and metabolically. Well, it's predisposed. We've already talked about the predispositions or genetics. There's nothing we can do about that. That's true. Regardless of if you want to acknowledge it or not, that's the truth. I've worked with some of the most elite populations on the planet. I do more assessments and tests and try to learn more about backgrounds and training and everything. And I've worked with a lot of South Asians too, and everything holds true. So more fat mass, abdominal, hepatic, visceral, issues with dyslipidemia, higher leptin, lower adiponectin, higher resistance, low lean mass, low muscle mass, low bone mass, a high fat to lean mass ratio, higher body fat percentage. Metabolically, we don't expend much energy. So the thing when people are measuring resting metabolic rate for South Asians, there is an adjustment where you could put your information in, but you'd want to address that are you South Asian or not, which would drop the resting metabolic rate calculation even lower because of having a lower amount of muscle mass and skeletal mass. Greater HOMA-IR, greater insulin levels, back from the genetic lecture before, that just shows that sometimes that's predisposed, but there is something you can do about it. 2 to 5 times higher type 2 diabetes risk, higher metabolic syndrome prevalence, increased hypertension risk, vitamin D deficiency, higher CRP. You look at just dyslipidemia is atrocious. And then we look at things from a cardiovascular perspective. Things are happening at least 10 years earlier. Higher mortality from CAD, coronary artery disease, higher type 2 diabetes, atherosclerotic cardiovascular disease prevalence. And a lot of it has to do with this exacerbating everything. And then we look at fitness, we're weak, poor exercise capacity, and we generate way more lactate at submax levels than any other group. This has been shown through a lot of the high performance people that I collaborate with and work with, and they're like, yeah, we've worked with South Asian populations, and we're blown away with some of the lactate readings we get on them, and some of the low VO2s and the low HRVs and the high resting heart rates that we see. There's a high amount of inactivity. We need to work 1.5 times harder to get the same results. And the thing is, if you're systematic about how you do it, you can get results. And I do this with my clients all the time. Nutritionally, low protein intake, high refined carbohydrate intake, high poor fat intake. That's another thing that goes along with that. Low fiber intake, low micronutrient intake. Greater than 80% of people are protein deficient. And this feeds into why this is potentially so poor, why this is an issue. This is an issue driving the number one killer of Indians across the globe. So this is building on the previous video where I talked about, from a genetic predisposition standpoint, why are we the way that we are, and what does the data show? Can we actually prove this? And it absolutely does. So building on our predispositions and our current health status, it's coming up with the solutions of what can somebody do. And I'm going to put that information together for you, so stay tuned.